present hyponatremia at some point. In patients, for example, in neurosurgical ITU units, the mortality can be as high as 60% in people who present hyponatremia. Everyone is aware of this problem because it is the most sort of topic in UpToDate. So it is a headache for many doctors, as we will see. And just very basically, we have a normal range for sodium, which is between 135 to 145 millimoles per liter. Anything above that is hypernatremia, anything below that is hyponatremia. And we can think that hyponatremia is an excess of water relatively to total body sodium, whereas hypernatremia would represent most of the time a loss of water in excess to any accompanying salt loss, but that's not necessarily the case. Grossly speaking, these natremias are any kind of water disorders, and this is because there is an imbalance between water, the intake and the loss, and the electrolytes that are dissolving this water. So any abnormality with sodium will always reflect an abnormality in water, whereas an abnormality in potassium is going to reflect on the heart. An abnormality on calcium will reflect on muscles. Then an abnormality in sodium, will be reflected in our water components, and well, it will have different manifestations. We could think that sodium will determine the volume status, and just in broadly speaking, if we were to have a lot of sodium, then we can think that the patient is hypervolemic. We will see when this happens. We will also consider that a patient who has normal amount of sodium will be euvolemic, and this we will see when this happens and when this doesn't happen. And a patient who has a low amount of sodium, and the patient will be hypovolemic, and we'll see when this happens too. Now, coming into any sodium talks, you'll see that we always have plenty of diagrams and flowcharts, and that's one of the things that make it difficult, is just to know which one is the right one, which one is the one that is going to help. I like this one because I think it gives you an idea on just how to begin to investigate for a sodium problem. And I think if we start at the beginning of the flow chart, then we'll just need to make sure that the patient actually has low sodium. And this is just to rule out pseudo-hyponatremia, which is when we can have solutes that appear to be lowering the sodium, but in reality it is not, such as, for example, very high lipids. Then the second step, if we confirm this sodium, and I will tell you later how to confirm this sodium, is just to assess if the patient has a low serum osmolality or not. I will show you in a moment how just to make a quick calculation of this. And if the patient has low sodium, but the patient is not hypotonic, then we will have to consider other causes that could be making his sodium go low, such as, for example, mannitol, very high sugar, radio contrast that we have used for a test that the patient has had. And then lastly, is just to measure how much sodium and electrolytes are coming off the urine. So the idea would be to measure the urine osmolality, see if the urine is being actually concentrated or not. If the urine that is coming out is not concentrated, we will assume that the patient has an excess of water intake, either because the patient has primary polydipsia or because the patient has a very low solute diet like tea and toast syndrome or hypotomania. These patients, they are not using their antidiuretic hormone because they don't have to produce concentrated urine. They have an excess of water, so there's no reason for them to do so. Whereas all the reasons to have hyponatremia that are interesting, and they are below this line, they are all antidiuretic hormone mediated. And in these old patients, we will see that the urine is concentrated. So for one or another reason, the neurohypophysis is producing enough ABP, and this in turn will cause different manifestations in our physical examination. If we assess the extracellular volume, we will see that there are patients that are going to be dry or appear to be dry. There are patients that are going to appear normal, and there are patients who will appear to be hypervolemic. No, the classic picture would be a patient with heart failure, a patient with liver disease and cirrhosis, a patient with nephrotic syndrome. Perhaps it may be more difficult to assess patients who are normal, such as patients who have some degree of glucocorticoid deficiency, patients who have taken thiazides, patients who just run a marathon, and well, patients who are dehydrated. Some of them are very evident. Patients who have had a massive diarrhea, patients who have been intoxicated with diuretics or burns, but sometimes it may not be very evident in patients who have adrenal insufficiency or other problems. This is one of the other flow charts that again can become difficult to read, but I think they all agree that part of it will require to assess the volume status, and we'll see that this is not very easy, but nonetheless, it gives you an idea that part of the evaluation of this problem will require to assess, for example, how much sodium we have in the urine. And although you see the different scope that the one I told you when you check the urine osmolality, you can begin to get an idea that depending on how much sodium you get in the urine, you'll assess if the patient is behaving correctly or not. So let's concentrate here in this second box here. Patients who appear to have a very low amount of sodium in the urine, well, they are saving sodium and therefore they are trying to save water. For what reason? Because they are dry. No? Patients who have extrarenal losses, patients who have had a burn, pancreatitis, diarrhea, vomiting. No? We can see, for example, on the other side, how it's very easy that these patients, they also have a low sodium in the urine, but they have an entirely different picture. No, these patients are hypovolemic, and these patients have cirrhosis or cardiac failure. The kidney behaves in a way that it wants to save water and it wants to save sodium, but the reason behind them are very, very different, and I'll try to explain this a bit later. But it's complementary to do the urinary sodium and the urinary osmolality. Is not going to give you the definite answer, but it's certainly going to help you to narrow down why this happened to the patient. So sodium is very important because in reality is the main component of the plasma osmolality. And we could barely say, well, we could say that osmolality is one way to regulate tonicity. So if we see in the first part of the graph that in the slide that I've showed you here, osmolality is just the quantity of sodium, glucose, and urea. And if the patient has alcohol in the blood, well, that also counts. And this will provide a certain degree of tension in the fluid that we have. And this is because we have some particles diluted in an amount of fluid. But now, tonicity is not the same as osmolality because these are just effective osmoles. These are the substances diluted in the fluid that will actually create a gradient in which substances will have to move following their concentrations. And we'll see that tonicity, well, again, importantly driven by sodium, by glucose, and the urea disappears for tonicity because the urea just moves freely across the membranes of the cells. So just to differentiate these two and why they are important is we can measure osmolality based on the blood test that we get provided, and we can try to calculate tonicity just considering that glucose and sodium are going to be the more important solids in the blood that will be driving the forces of Stirling. Osmolality doesn't change, it's the same across the body, whereas tonicity, it does change, and it will be located mainly, obviously, in the extracellular component, and particularly when it comes to serum and blood. It is important that we're aware of this because depending on the tonicity of the patient and the tonicity of the solutions that we give the patient, we may cause effect to their cells. So an isotonic fluid, when the patient has an osmolality or a tonicity nearly 300, will not change the size of the cells, whereas if we expose, for example, a patient with a substance that will increase the amount of water inside the cell, and this is, for example, if we provide the patient with hypotonic fluid, we will cause edema of the cell. And if we expose the patient to a hypertonic fluid or solution, or if we create a gradient that will drive fluid out of the cell, we will call shrinking of the cell. And this we'll have to remember later, because this is why some of the most worrisome characteristics of hyponatremia behave, because this is what's happening to the neurons in the brain. So just to remember, we always follow a concentration gradient, and that means that from where we have more to where we have less, we will just try to equilibrate. So in this case, for example, if a solute, in this case, let's suppose this is sodium, cannot move across the membrane, one way or another, water molecule will try to move just to equilibrate and just try to leave it equal. There are substances that are going to move freely and they are not going to make water move, like, for example, urea. Urea moves freely and therefore, for example, it doesn't drag any water. So we can see, for example, why patients who present significant abnormalities in their sodium, they can present these severe manifestations of cerebral edema, whereas in patients that they don't present these abnormalities, for example, patients with kidney failure, well, cerebral edema is not a manifestation of, sorry for that. Cerebral edema is not a manifestation of kidney failure, and this is because urea in reality doesn't affect the passage of fluid from one side of the membrane to another. Now, to regulate body tonicity, or in this case, to affect the osmolality of the fluids, we'll have a hormone that is produced centrally, and this is vasopressin. Vasopressin comes from the hypothalamus, where it's going to be passed to the posterior pituitary gland, and it will just be released whenever there is a stimuli that will make it come out. So the half-life is between 15 to 20 minutes, and the most common and most important stimuli for this one to be released, ABP, is hypovolemia. A patient who presents low volume will present ABP, and ABP, what it's going to create is just going to make sure that the patient, or the nephron in this case, reabsorbs water. So we can see how in a circumstances in which the plasma osmolality has increased, and that means that the blood has become concentrated, or the patient is dehydrated, this will activate the hypothalamus. It will create the secretion from ABP from the neurohypophysis into the pituitary gland, and it will be secreted. This, at the same time, will generate thirst, will make us drink. This will affect negatively the plasma osmolality, and hopefully it will decrease the secretion of ABP. And ABP, well, it's going to travel to the kidneys and is going to work in the last part of the nephron, where it's going to make the patient absorb water. There are other causes to secrete ADH or ABP, such as pain, nausea, pregnancy, some medications. And the most important stimuli we always need to remember is hypovolemia. If the patient is dry, that's going to be the strongest. This is going to be the one that is going to win over the osmotic stimuli. The osmotic stimuli is important, but not as much as having poor perfusion. We can demonstrate this when they study patients who are in several states of fluid balance. So patients who are euvolemic, if the plasma osmolarity begins to concentrate, so we can see how it moves from 280 towards 300. Obviously, the secretion of ABP increases, but in patients who are already dry, in patients who are hypovolemic, this ABP secretion increases even before that happens, and in patients who are hypervolemic, this response is blunted and delayed. So as you get from these images, the most important feature to secrete ADH is going to be dry. And this is just another graph that it's really similar to the previous one, but it shows that as much as we increase our plasma osmolality, we will be increasing our secretion of ABP. And that in turn will cause the urine to become more concentrated, and that will decrease our urine output. So in a circumstance where the patient has free access to water, for example, patients with psychogenic polydipsia, well, these patients, obviously, because they have so much fluid and they become diluted, they don't have any reasons to secrete ABP. So the urine is going to be completely diluted, and they are going to be producing 14, 16, even 20 liters of urine per day. It's not enough, perhaps, to match what they are drinking, and that will cause hyponatremia. Why? Because there is excess of water that is diluting their sodium. But let's go the other way around. We have a patient who's been vomiting. We have a patient who has been also taking a diuretic, and the patient has become dry. Obviously, this will increase the osmolarity in plasma. This will make the ABP go high, and the patient will produce little but very concentrated urine. So that's the relationship between those two states. It's very broad to say, but I think it's fairly easy to understand. Now, it works mainly in the collector tubule of the kidney. So we have that's a nephron. We remember here is the glomeruli. Here are the proximal nephron is just here at the middle of the loop of Henle. And after that, we have the distal nephron with the distal covulated tubule and the collector tubule. And this is the area where ABP is going to work. It is going to block the presence of aquaporin, and therefore the medulla won't be able to. It will generate the appearance of aquaporin, and therefore the medulla is going to absorb all the fluid that is there, that is arriving to that part. We can see how the nephron is only sensitive to ABP or to desmopressin just in the later parts of the nephron. As I said, in the collecting tubule, the rest of the nephron is not affected by its presence. And what it happens is that in a circumstance in which we don't need to absorb all that much water because we have an excess of water, so aquaporin too gets destroyed inside the cell. But if we have an stimuli by ADH, what is going to happen is the aquaporin will actually be active. It will be actively transcribed in the cell, in the nucleus of the cell, to produce more into the luminal membrane of the cells. And the more aquaporin there will be, the more water will be absorbed. And the more water will be absorbed, obviously, we will produce a more concentrated urine. So that's pretty much the effect of the antidiuretic hormone. Now, the kidney has to become hypertonic to work well. So just going back to this slide, I just would like to remind you that it is the medulla of the kidney that is hypertonic, and the cortex of the kidney is never hypertonic. So in a circumstance when the patient needs to reabsorb water because the patient is otherwise dry, what is going to happen is that the medulla will become hypertonic by the loop of Henle and by the collector tubule, that together they are going to be working in absorbing more and more water and solids. And when this is not needed, then the medulla is going to be working less. The loop of Henle will decrease the output the same as the collector tubule, and well, the patient will be able to excrete diluted water because there's no need to reabsorb it. I think this has already been explained, and how urine volume changes based on ABP, and also the more concentrated the urine, the smaller the amount of urine we produce. Now, when it comes to sodium, we have to think that it's not the only thing that is affecting the patient. As I said, it's going to be affected by total body water, and it's going to be also affected by potassium, because we have to remember that sodium is outside the cells and is just in equilibrium with the potassium we have inside the cells. So we could begin to think that some reasons to have hyponatremia would be related to the amount of sodium we actually have in total in our system. So, for example, in a patient that has poor sodium intake, like in tea and toast, or in patients who have had a thiazide diuretic, that might cause by itself to have a low sodium, because the amount of sodium in the body is low, no? We may think, for example, that in SIADH we are losing we are not losing that much sodium, but there is a bit, just slight, because there is some urine output that will produce this urine to come out. So again, the total stores of sodium are decreased. Or, for example, in patients in which we have excess of water, then we will produce sodium retention. And these patients will be hyponatremic, but because they are actually hypervolemic, despite the fact that there could be a bit of sodium retention. Now let's see when it comes to potassium. The potassium is interesting because it can also have effects on the sodium. The patients who have very poor potassium intake, patients who have, for example, loss of potassium, such as patients, for example, for diuretics, this could also be a cause why the potassium can go low. And these patients will also create a problem where sodium can drop in the blood as a consequence of just losing potassium. Again, the same is in SIADH, this can happen. If the problem is located in the amount of water the patient has, well, this will also drive the sodium down. In patients in which we are not passing as much water as we should, and water water retention is and water excretion and retention is abnormal, then we can get hyponatremia. So just to give us an idea, in patients with hypovolemic hyponatremia, the amount of urine that comes out is not normal. So because there is water retention, this can dilate the sodium. In patients who are hyponatremia, but with normal total body water, there is an amount of water that gets inside, but again normalizes with the amount of sodium we have, but the total sodium stores decrease. And in patients who are hypervolemic or euvolemic, there is just because they have an excess of water that expands the total body water intake of the system, and this dilutes the sodium. I think it's more interesting to see what is happening in the brain. So if we start on the left side of the screen, we'll see how when we begin to decrease the osmolality, and this is we dilute our system, the brain swells, and this is because the neurons are not that effective at protecting themselves from these changes in osmolality. But there is adaptation, and in chronic hyponatremia, this adaptation actually is very helpful for the patients to prevent them from developing significant symptoms. Now, if there is removal of fluid, either because there is slow adaptation or because we have not been treating the patient properly, we're going to cause a significant amount of fluid shift from the neurons to the outside of them. And if it's improper therapy or this was not properly monitored, we're going to get osmotic demyelinization. Whereas if we actually are careful in monitoring and giving the treatment that the patient wants, well, they will return to a normal osmolality, and the brain tissue shouldn't suffer this demyelination that it can happen if the treatment is not observed. So just to remember then, in early stages of hyponatremia, the brain swells. Towards the hyponatremia becomes chronic, the cells in the brain returns to a normal size, and that's why patients don't develop that many symptoms when they have chronic hyponatremia. If treatment was excessive, obviously there's further shrinking, and this is because there is demyelinization. And this is the image they get. So these patients here, we can see how in the pons, this black image here in the center just means that this patient has actually had the worst consequence of rapid corrections of hyponatremia. So for practical approach, so first step would be to reassess if the patient has severe hyponatremia or not. This will be defined obviously if the patient has obtundation, if the patient has seizures. Those are the most worrisome symptoms. The next step would be to check serum osmolality. We will have to rule out pseudo-hyponatremia. To do this, we would use normal blood gas. I'll explain to you in a second. We also have to check lipids. We have to check total proteins and bilirubin. If the serum osmolality is high, then we will have to think if this hyponatremia is actually reactive to some other drug that is causing this number to go down, such as high glucose or mannitol, immunoglobulins, contrast. Or the one that we are actually going to be facing with most of our patients is true hyponatremia, when it is hypotonic. I was telling you a moment ago that the idea would be that to make sure that we rule out pseudohyponatremia with a blood gas, and this is because non-active osmols such as urea and alcohol may mask true hyponatremia. So it's always a good idea to check with a gasometer that the value of the sodium is accurate. The next step would be just to check in the urine for the osmolality or a specific gravity. So the specific gravity in the urine will go higher the more concentrated the urine is, although it is more accurate to measure the urine osmolality, but it takes time. And it will tell us the presence of ABP. So if the patient ABP is appropriate, it's very likely that we're going to be facing a hyponatremia that is not related to excess of free water intake. Lastly, we have just to assess the urinary electrolytes, and we'll have to also check urate. And this is because they will also give us an idea if this patient has any other features such as SIADH, or if the patient has other abnormalities that could be causing this problem. Now, when it comes to the assessment of the extracellular fluid volume, well, this is challenging, and this is because the clinical examination is not perfect. And for many years now, we have known that clinical examination may only be actual in half of the cases. So it would be pretty much like tossing a coin to assess if the patient is euvolemic or hypervolemic. In your case, obviously, if you have the ability to use ultrasound, bedside ultrasound, and POCUS, this will increase the sensitivity of your examination, and this will make it easier for you to identify where you are. But just bedside examination, particularly, for example, in medical wards, becomes more challenging if they don't have access to ultrasound. And well, just to remember, if the patient has other concomitant problems, such as drugs, patients who have been taking thiazides, antidepressants, patients who have had an overdose with a drug like ecstasy, this could all cause significant declines in sodium value. I think that if we are actually facing a hypotonic hyponatremia, and this is because we are measuring a low serum osmolality, we have just to try to identify if this patient has hypovolemia, euvolemia, or hypervolemia. If the urine osmolality is very low, then again, we have a patient who has been drinking just too much, such as the disease listed there. And if we, just as a rule of thumb, if we notice that the urine osmolality is greater than the serum osmolality, that means that the patient is releasing ABP. And if the patient is releasing ABP, then we'll have to think any of the three below. So in patients with hypervolemia, heart failure, in patients who are euvolemic or hypovolemic, and this is where it may become challenging, the physical examination. Low urinary sodium will represent hypovolemia, and that's an adequate response from the kidney. Whereas in patients with euvolemia, this urinary sodium might not be low at all. It's important, obviously, to rule out hypercortisolism and hypothyroidism, because they all can create euvolemic hyponatremia that with treatment will improve. Now, when it comes to treatment, things have changed, and I suppose that if you were to interview old consultants, they will all be concerned on how to treat hyponatremia. And these two different papers are 20 years apart. So in 1990, this consultant in the United States considered that treating or not treating hyponatremia was always a bad story. And he gives the two cases in which one patient developed hyponatremia after a surgery. The patient only got treatment with 5% dextrose. Because of that, the patient presented significant hyponatremia, around 100 convulsions. The patient died. And then on the other hand, they have a patient with hyponatremia. The patient got into hypertonic saline. It was not properly monitored, and the patient died too. So this was experience when they didn't understand very well what they were doing. They didn't have all the concepts about sodium regulation very clear. And now in this paper that is 12 years old, but 20 years from the original one that I show you, they tell us of a patient who got intoxication with a thiazide, fluoxetine, drinking beer, and hypovolemic. And this patient with a sodium of 96 got a successful recovery, and the patient didn't have any significant sequelae following his discharge and the treatment they provided. I will tell you about the treatment they gave. I think the success and how we approach hyponatremia is because we understand it better. And we know that on the left side of the slide, you can see that actually sodium is distributed uneven in the body. So the plasma only takes 10% of our sodium. Intracellular, we have very little, 2.5%. And we can see that the white spaces in that graphs are sodium that we can exchange, either in the interstitial fluid, in the bone that is susceptible to exchange. And there are parts that we are going to be able to exchange, such as in cartilage, in bone, and in these areas that are actually sodium avid, the sodium is never going to go out. In the right side of the slide, what I want you to see is that we should be always in balance. So in homeostasis, whatever we are having as an intake, the amount of sodium, potassium, and water should actually be similar to the output, to whatever we are losing through urine, to sweat, to stools. And the plasma sodium concentration is just the reflection of whatever we are having on our day-to-day life. We are better at treating hyponatremia because we also understand that not all fluids are the same. So now we know very well that sodium chloride is not the same as Hartmann's, is not the same as 5% dextrose. And if we know how to use them, and if we know when is the right moment to take the best of them, we will try to make it better for the patients. And it's just to identify how different the plasma concentration is different from the IV fluids that we're giving to patients. Hyponatremia and hypernatremia, they are challenging when it comes to the neurological consequences of these problems not treated well. And I want you to see here, for example, on the left side of the screen, how osmotic demyelination happens. And this is because either we have a patient with hyponatremia that we corrected too fast, or because a patient just developed very rapid hypernatremia. This will just cause what it would be shrinking of the neuron mass, and this in turn will destroy the myelin surrounding the neurons. Whereas on the right side of the slide, we see how a patient who has had a very rapid onset of hyponatremia, or a patient who got corrected hypernatremia very quickly, will produce cerebral edema, no? And there is a risk of uncalernation and possibly death for this from happening. And we just need to remember that this can happen any time with patients that we face when they come into the hospital for different reasons, and as you will see in the cases that I will present to you. When it comes to treat hyponatremia and hypernatremia, we have to be aware that there is a time frame to do so. And for example, in patients who we believe that the patient has had, for example, presented an intoxication with ecstasy, a patient who has run in marathon, and the patient has severe hyponatremia, and this is a hyponatremia less than 120, in which the clinical features will be headache, will be vomiting, will be coma, seizures. We will have to initially treat this patient with 3% sodium chloride. If this hyponatremia happened just over several hours, excessive correction may not cause any harm. Whereas if we go to the lower part of this slide, if the patient has had, for example, an unknown time with hyponatremia less than 120, we may risk this patient presenting osmotic demyelination, and this is when we increase, for example, the amount of sodium more than 6 millimoles per day. In some series, they recommend not to go by more than 10 per day, but failure to do so is likely the cause for significant damage to the patient and to his outcomes. Now, in hypernatremia, it's very similarly the timing. So if the hypernatremia has settled very quickly, excessive correction may not be harmful, but in patients who are unknown or who have had them for many days, we also have to provide treatment that goes slow, because the quicker we go, the easier we get complications. Let's see with the cases, because I think it's going to be easier to understand. So we have a 30-year-old female who was brought from A&E, and she's unresponsive. She's previously healthy. She was in a party. The physical examination shows a Glasgow Coma scale of 10. Rest is unremarkable, and someone tells you that during the party someone get her ecstasy. So she gets a liter of saline because someone put a line in her, and she starts having a seizure. When the blood tests come back, we see that she has a sodium of 120. Her creatinine is 60. Her bicarbonate is 24. So obviously we panic, because the seizure is a manifestation of severe hyponatremia and is one of the dangerous ones. So if this patient presents acute severe symptomatic hyponatremia, we have just to consider these possibilities: water intoxication, patients who, for example, go to a drinking contest, exercise related, people who have recently run a marathon with excess of fluid, patients who have taken ecstasies, iatrogenic. As mentioned before, the manifestations mainly neurological, but it can also cause non-cardiogenic pulmonary edema. And the treatment will always require hypertonic saline. We have 3% sodium chloride, and the idea would be to provide them with 1 or 3 boluses, depending on clinical needs. 2 different approaches, either 100 milliliters every 10 minutes or 150 every 20 minutes, until we assess actually that the sodium has increased by approximately 6 millimoles and that the symptoms have disappeared. This would be the goal of the treatment, and this is the quick way to treat a patient who has presented these acute severe symptoms. Now, if the patient does not present seizures but still has a very low sodium, 110, 115, you may consider actually a hypertonic sodium chloride infusion. That is also something that we can do. There are formulas to try to calculate what is going to be the change in sodium. So this formula that comes, this paper from Adroga and Madias in 2012 is interesting, but it shows that the calculated amount of sodium and potassium and an infusate versus resting the amount of sodium in blood and challenged by the total body water plus a constant of 1 will give you just the degree of change in sodium. In practice, we don't use this because it's just bothersome, but it's just to get us an idea that in patients who require a sodium infusion, we might be able to calculate how much is going to change for every liter we give. And just to remember that the concentration of sodium in each fluid that we provide is different. The higher the concentration, well, the higher the amount of sodium we provide. There are calculators that this helps too. This is just in an iPhone. It's a MedCalc. I don't know if you use them in ITU or not, but it's one way or another just to give us an idea on how much you can calculate the sodium will increase. The only problem there is that it doesn't really take into account how much urine you're producing, and therefore, because that could be also a challenge to the system, this may not be entirely accurate. So that's why many people, they don't use them. But as a rule of thumb, we can think that 3% saline at 1 milliliter per kilogram per hour will increase the sodium by 1 millimole liter hour. Again, this is just something that is a good idea just to know how to, but the most important thing is to monitor. And in these patients, when they present acute severe hyponatremia, it is important that we remember to monitor, perhaps at the beginning every 2 to 4 hours. Later in the day, if the sodium is actually getting into the right direction and the patient doesn't have any significant symptoms, every 6 to 8 hours, and perhaps a few days later we can slow down, test every 12 to 24 hours. Again, monitoring is very important. There have been trials to see how they do. Either they give intermittent boluses or they give a slow continuous infusion. And we know that they are actually equally effective in this for this outcome, and they don't have a significant difference in overcorrection risk. Nonetheless, it happens. And as you can see here in this graph, for the patients that they investigated, which were nearly 180 patients, there were around 20 patients in each arm that got overcorrection. So I will tell you something on how to avoid this in a moment, okay? Now, if the patient begins to pass a lot of urine after you given hypertonic sodium chloride, will it affect how much the patient behaves? And it will, and you will see in a moment why. There are formulas, again, because all these sodium books, they always talk about formulas, but depending on how much water you excrete and calculating the amount of electrolytes in the urine and in the serum, you may consider that the amount of urine that the patient produces may not have an impact. It will cause the sodium to go even lower. For example, if the amount of sodium in the urine remains very high, or if the amount of sodium in the urine actually decreases, then you may think that it will not make your sodium go lower. On the contrary, it will make your serum sodium go higher. Again, formulas that I don't think it's very useful on ITU, especially when you're very busy or you have many things going on. But it does have an advantage, is that you don't really need to be chasing urinary osmolality, especially if it takes a lot of time for it to come back. But again, I think the most important thing here to do is just to monitor the patient and just to make sure that we are doing regular testing for sodium. This same paper shows the effect of adding, for example, fluids into different patients. So let's just go for the first patient. In a patient who has presented hyponatremia because the patient has had a thiazide, they are presenting the same amounts of solids in the urine and they are presenting the same amounts of sodium in the blood. So in this case, for every liter of urine they present, it's not really going to change the sodium in their blood. It's not the same, for example, in a patient who has primary polydipsia. In a patient who has primary polydipsia, whose urine is coming extremely diluted with a sodium concentration less than 20 and whose serum sodium is 20, the more urine they pass, the more it will impact the sodium in their blood. So for every liter of urine they produce, we could expect that the sodium will go up just by itself 2.7. These are examples calculated by the previous formulas I showed you, and obviously they do have clinical translation, but probably it's just not very useful on ITU. But we have to be aware that depending on the solution we give to the patient, we are going to have an effect on sodium. So if we go to the left side of the screen, a patient who receives 3% sodium chloride, 1 liter of sodium chloride may cause the sodium to go up 13. A patient who receives sodium chloride 0.9%, a whole bag may increase the sodium 1.4. A patient who receives 5% dextrose is going to drop the sodium 3.5. Whereas if we go for the other side, if a patient presents fluid loss, for example, a patient who presents in primary polydipsia diluted urine, if the patient begins to pass urine, for every liter of urine they pass, the sodium is going to increase 3.1. This is when we restrict them from water. No? A patient who has osmotic diarrhea, if we provide for every liter of diarrhea, the sodium will increase 2.4. So it will depend on the fluid that we're giving that we're going to have changes on the serum sodium, and it's important to be aware. So that not all patients will respond the same, but we can have an idea on where this will go. But again, it's monitoring. This is another case, and this will have a different context. This is a 54-year-old man with colon cancer, multiple abdominal surgeries, has an ileostomy, and because he has an increased output, he has presented hypotension. He's dry. Previous history of type 2 diabetes, the physical examination, blood pressure 90/60, and this is just after 2 liters of sodium chloride. His heart rate remains high. He doesn't appear to be edematous. The issue is that we've done the blood test, and before he received the 2 liters of sodium chloride, his sodium was 110. 2 liters after the treatment, his sodium has gone up to 120. Now, we are worried because we know that his serum osmolality is low, and within a couple of hours, we have made his sodium change 10 points. So we suspect this patient because he's hypovolemic. This might be acute, but again, there's no way to confirm and how many days this has happened. We checked his urine upon admission. His serum osmolality was his urine osmolality was concentrated 690. The urine sodium was low, 20. So clearly the patient was producing concentrated urine. Despite the fluid, the patient has only passed 350 milliliters of fluid in the past 2 hours. And despite the fluid that we're given, the urine osmolality remains a bit high. The patient still presents low amounts of sodium in the urine. So we are concerned because the rate of correction has been quick, and we're not so sure we have achieved what we wanted. Now, the most worrisome thing here is that in a very short period of time, the patient has increased the sodium amount. So this patient is at risk of demyelination. And he has risk factors, chronic hyponatremia, because we don't know when this happened, sodium that is below 110. If the patients, they have low potassium, if they have liver disease, if they are malnourished, if they have had alcohol, or if the doctor treating them, they are not careful, they are all at risk of demyelination. Now, there are patients who are also at risk of overcorrection, and these are patients who are volume depleted. These are patients who have hyponatremia not driven by IDH, or patients who present adrenal insufficiency. Patients with SIADH, which is one of the most common forms of hyponatremia we see in the hospital, they are at low risk. We know that rapid correction of hyponatremia will cause these problems. This is very old, but nearly 30 years ago, they identified that a safe correction of less than 12 millimoles per hour will make uncomplicated recoveries to patients. And they realized that in patients with chronic hyponatremia that were corrected quickly, pretty much in half of them, there were going to be permanent damage. And other part of the patients, they will have temporal damage if they were corrected more than 12 millimoles in 24 hours, or 18 millimoles in 48 hours. Now, acute cases, we know already it's unlikely that they will cause any significant damage. Why this happens? Why do patients, once they get a bit of fluid, they can overcorrect themselves very quickly? Well, this is because actually we stop the ABP from working. So in patients who are dehydrated, they are producing a lot of ABP. We already talked about this. Hypovolemia is one of the main reasons why we produce ABP. And if we avoid hypovolemia developing, because we have given the patient some fluid, ABP disappears, and this will help to shoot up the sodium that we're trying to correct. So patients will reach quickly and without problems the normal sodium range, and this shouldn't happen. Because in theory, we're monitoring these patients, and because we just talked a moment ago that we would want this correction to go fairly slow. We don't want it to be happening quickly. So when we begin to understand this several years ago, that's when someone had the idea that perhaps they could develop something called the ABP clamp. and I'm not so sure if you're very familiar with it, but it would be just to give these patients desmopressin every certain amount of time to prevent this overcorrection from happening. We also have other strategies. We may consider, for example, 5% dextrose to be given or not. But in these patients, when they are given hypertonic soy and they are water restricted, perhaps the DABP will be the best therapy to give when we are correcting quickly sodium. And I don't know if you remember, but a moment ago I showed you that the two papers that were 20 years apart. This is the paper that was published in 2010, and this is about a patient who presented with a sodium of 96. They were very concerned because the patient had several reasons why he has hyponatremia. So what they did with this patient is, apart from giving him 3% sodium chloride, they gave him desmopressin every 6 hours. And they did this for 4 days. The idea was that instead of allowing the sodium to quickly correct itself by removing the ABP stimuli, because they were correcting hypovolemia, what they do is they continue to provide DDABP in a form as desmopressin, and this helped to make the sodium correction go as slow as they wanted. And the patient nearly stayed in the hospital for 2 weeks, but by the time of the discharge and in following an MRI, the patient didn't have any damage related to this correction from a sodium of 96 to a normal sodium. Obviously, the offending agents were removed, the thiazides, the antidepressant, the patient was not drinking alcohol. So we also have to consider that to achieve safe correction, we also have to remove the stimuli that is causing that. I think we have to be aware when we're treating patients and how fast we want to correct these symptoms, that if we have patients who have acute hyponatremia or chronic hyponatremia, patients who present acute hyponatremia, it's unlikely they will get damaged. Patients with chronic hyponatremia, we begin to get the idea that perhaps even to go slower is even safer. In patients, for example, with severe symptoms, we would go perhaps for even just 8 millimoles in 24 hours rather than the 12 that were originally described. And in 48 hours, perhaps we would dare to aim for 18 millimoles. But again, this may change depending on how we're treating the patients. There are strategies to using the DABP or desmopressin. And there are 3 different ones. One is called proactive, and this is a patient that immediately at admission, the patient receives desmopressin, receives 3% sodium chloride, and in theory, the people can feel relaxed and they can go to sleep because they know that the sodium is not going to increase very quickly despite the 3% sodium chloride. There is another strategy called reactive, which is what most people would favor. And in this case, based on testing urine osmolality and assessing how are the patient electrolytes, is just to treat with 3% sodium chloride if needed, or 0.9% sodium chloride if needed, plus desmopressin, and well, just to monitor and be vigilant. And the one they don't recommend, which is the rescue therapy, in which we already caused a significant amount of sodium shift, and the sodium has gone up beyond what we wanted. So we have to rescue the patient, and we have to give the patient 5% dextrose plus desmopressin. And we will be worried because obviously the patient is still at risk of presenting demyelination. So if we were just to consider that the DDABP can be used safely, and we know we would want to know if there is evidence that it works. And well, there is. This is a retrospective cohort in Canada, in which they assessed nearly 1,500 patients. These patients, they got DDABP in nearly 20% of them. And what they saw is that in the patients that had DDABP, they had a lower mortality rate, although they had to stay a bit longer in the hospital. But interestingly, they didn't overcorrect as many patients as they were doing it with the standard therapy. So in the proactive arm, it is the patients who receive DDABP before they given any sodium. These patients, they had a safe correction in 96% of the times. In patients who had a reactive, that means patients would receive DDAVP after sodium treatment was given, they still achieve a very decent 82%. In patients who had a rescue therapy and patients who already experienced a very high sodium and they received DDAVP, obviously, well, it was not a safe correction. And we can see that for these patients, well, to receive DDAVP was considered at that moment that it was helpful because it reduced the mortality rate because they corrected their sodium at a pace that was acceptable to their doctors, and it had the downside that it caused patients to stay a bit longer in the hospital. So until now is just that we should always consider that unless we have actually witnessed how fast the hyponatremia has developed, to consider it as chronic, just to recheck sodium frequently, particularly during the first days of the treatment. It's a good idea to check urine electrolytes, osmolarity, output. We should try to aim not to correct more than 8 millimoles in the first 24 hours. We may be able to correct another 10 millimoles the next day. It's important that we restrict free water intake in patients. We want to monitor them and we don't need them to have excess of fluid during the time they are there. And this one, although I didn't show any about it, but furosemide can be used for volume control if the patient is developing excess of fluid or if the patient presents impending symptoms of pulmonary edema, furosemide can be considered. But then again, being in ITU, well, you can always filter a patient. This is another case. This is for neurosurgery. This is a 44-year-old man with a subarachnoid hemorrhage. This patient came from theater after the clipping of the aneurysm. The patient was healthy. And physical examination, a patient that was intubated with a blood pressure of 140/90, a bit of tachycardic, but the rest was okay. The problem is that a few hours later, it shows that the patient from a sodium of 135 has dropped to 129, and this is between 6 hours. No? And this is worrisome because the patient has developed hypotonic hyponatremia. Now, we don't know exactly how fast this can get or how worse this can happen, but we know that in neurosurgical patients, hyponatremia is always something dreadful. We test for his urine. We assess that the patient has a urine osmolarity of 700, so the patient is producing DDAVP. He's losing a lot of sodium in the urine. So we see there that the patient is passing very concentrated urine with a lot of sodium. Normal cortisol, time with tests, and we are wondering, could this patient have SIADH because the patient just had a neurosurgical procedure, or could this be cerebral salt wasting? This is not a newer syndrome, but there is no clear definition if it exists or not. In neurosurgical ITUs and neurosurgeons, they really believe in this entity. Here in nephrology, well, we are a bit more cautious about it, but we recognize that patients who have had a neurosurgery, they are at risk of hyponatremia. SIADH is a hyponatremia that is hypotonic. It usually has a good amount of sodium in the urine. They usually have low urate. We know that if we give these patients sodium chloride, they will decrease their sodium because they will retain just free water. They have normal thyroid and cortisol. And we know that if we give them a good amount of fluid in 4 hours, they are not going to excrete all of it at the beginning of the treatment. There are many reasons why to have SIADH, and I think the list can be longer. But just to remember, many drugs that we use, patients with pulmonary disease, patients with HIV, they can all get SIADH. Now, patients, they don't respond very well to sodium chloride or normal saline, and this is because they already lost the ability to the ability to pass enough free water in the urine. What it seems is that these patients are not having enough sodium. So just to get you an idea, and I think this would be easier to understand. In a patient with SIADH, if we give this patient 154 millimoles more of sodium per liter, which is nearly 300 millismoles in a bag of fluid, the patient would have one fluid, but is not going to gain. It is not really going to gain any extra sodium. Whereas if we treat patients with SIADH with hypertonic sodium, we're going to make sure these patients increase their sodium by losing free water. Now, one of the treatments that we should consider always for SIADH is not necessarily to give 3% sodium. 3% sodium probably will only be reserved for patients who have severe symptomatic hyponatremia, but it's just to restrict the patient. The fact that we are actually asking the patient not to have enough fluids, or that we may consider the use of loop diuretics, might just be enough to remove free water and then to increase therefore the sodium of these patients. So just going back to SIADH and cerebral salt wasting in the neurosurgical unit, I think the main difference are exemplified here, and at the same time the similarities between those two symptoms. So in a patient with SIADH, they tend to have a low urinary volume, whereas a patient with cerebral salt wasting, they are passing a lot of urine. They lose weight. Patients who have apparently cerebral salt wasting, so much urine they are passing that they became dehydrated, whereas patients in SIADH, if any, they gain a bit of weight. We know that they don't respond very well to sodium chloride, whereas in patients with cerebral salt wasting, sodium chloride can increase their sodium, and there are many similarities. Serum osmolarity is low, urinary osmolarity is high, their uric acid in blood is low, and this is because there is dysfunction of the proximal nephron. After treatment and before treatment, there's a way to see how sodium in both of them, in SIADH and cerebral salt wasting, may increase. The difference there is that uric acid will remain abnormal, and that's why they calculate fractional excretion of uric acid, although we don't do that here. And cerebral salt wasting, I think, is important just to remember that it may happen in patients with subarachnoid hemorrhage. Patients are hypovolemic, they may lose weight, they have very good urinary volume compared to SIADH. That if we give them sodium chloride, their urinary sodium and urinary osmolarity will decrease. Now, I think in nephrology, the issue is that we don't believe this much because all segments of the nephron are permeable to sodium. So there are only very rare occasions where this can happen. For example, in patients where they develop toxicity because of cisplatinum. In patients with cortisol deficiency, this might be exacerbated. In patients with thiazide, this might be exacerbated, but it's not very common. The rationale to believe in this entity is because actually central nervous system disease will create, for once, what is decreased sodium reabsorption, and therefore major delivery of sodium to the distal nephron, which called natriuresis. And at the same time, because the patient has because of the surgery or whatever the patient has gone through, decreased cellular reabsorption inside the kidney. This will reduce the effective arterial blood volume, this will increase ABP, and this will increase urinary concentration, leading into hyponatremia. And it's a very different pathway compared to the common development of SIADH. So that's why some insist that it exists. We could say that it doesn't matter. The treatment is going to be very similar to monitor and just to make sure that the patient doesn't develop a rapid correction of hyponatremia. Water restriction, contrary to SIADH, is discouraged. In this case, the treatment will be probably to give sodium chloride either 0.9% if the patient is not at risk of having seizures at that very moment, or if the drop has been significant, like in our patient that the drop was around 7 points, well, we might consider to give 3% sodium chloride to correct the sudden drop in sodium. The recommended treatment for these patients is that for every sodium drop more than 5 millimoles in 24 hours, either to consider sodium chloride tablets or to give just a slow infusion of 3% sodium chloride. Now, the important thing here is just to check sodium every few hours and just to modify the infusion according to the needs. This problem with cerebral salt wasting is that it may not respond always to sodium chloride, but it usually does. And if it doesn't, then we will have to think of other reasons why this response might be blunted. For example, in patients who have adrenal insufficiency, in patients who have other factors going on, like any other reasons why they might be able to lose sodium in the urine if there is another medication that it's not been removed. For example, antidepressants or other medications that could be affecting them. Patients who develop hyponatremia because they develop edema, there are just a number of reasons why this could happen. Patients with decreased cardiac output, or patients who have what appears to be like a low perfusion state. These patients, they will develop an avid sodium retention and water, and that's why these patients develop that most of the time edema, but they remain hyponatremic because the amount of fluid they retain is greater than the amount of sodium they keep. Now, similarly, patients with nephrotic syndrome and patients with liver cirrhosis behave similarly, although their nature of the problem is different. And well, just to remember that with these patients, the idea is that to limit fluid intake, so we may actually increase the output as much as possible with the idea to correct the excess of fluid that the patient has. And that's very, I'm not getting into much detail here, but I think it's because I think you very well know how to treat heart failure and excess of fluid, but I didn't want to lose that much time talking about this. And this is the last case and about dialysis, and I think this is one of the most challenging ones. This is a 74-year-old female, septic shock, acute kidney injury, goes with you. She's anuric, she's on vasopressor, she has had inotropes. The patient has had kidney disease in the past, liver cirrhosis, she's intubated, hypotensive, and edematous. Her blood tests are horrible, potassium of 6.2, bicarbonate of 12, creatinine 345, urea of 66. So clearly the patient needs to go into the filter. Now the problem is that the sodium is very low. How are we going to be dealing with that? Because we don't know how fast this hyponatremia developed. We could think that overcorrection in dialysis patients, it may not cause problems. We don't know what is the real incidence of demyelination in patients in dialysis or with chronic kidney disease. If any, there are very few reported cases, and we may think that patients with a kidney injury or chronic kidney disease might be protected from developing this issue. It could be possible that they are protected with urea, but because we don't know, it's better to be on the safe side, and that means not to cause any harm. So if we want to just take it easy and we don't want to actually increase their sodium by using the filter, we'll just have to think if we will have to alter the treatment we're going to provide. This is the way they do in Canada. This is not something we tend to do here in the UK, but if we can see in a patient who has a serum sodium less than 120, there has to be a discussion if we can actually modify the continuous renal replacement therapy, and this is just to try to establish that by modifying the fluid content of the bags, we may achieve a desired correction of sodium. We will have to be involved with pharmacists. We will have to be modifying the fluid bags, and obviously it is time consuming and it's burdensome, but it's an approach that in some places they can use, although we don't use them here. So One method it would be to customize the solutions. So what we could do here is add free water. By adding free water into the bags, we're going to reduce the amount of sodium, and we'll see here, for example, if we don't add anything, the bag is going to have a sodium of 140. If we add half a liter of free water, the sodium is going to end up 127. If we add 1 liter, the sodium is going to be 116. So it could always be possible to do this, although it will depend on the policies of each center to do it and how easy it is for their pharmacist or the staff who actually deals with this to perform it. It's not easy, as I said, and it's better just to keep things simple. The method number 2, and that perhaps this is not necessarily that difficult, is just to consider the addition of 5% dextrose into the post-filter fluid. And by doing so, by adding a hypotonic solution, we're going to actually making the sodium in the circuit lower. Again, not a lot of people use this. There are some units that are using it, and the rationale is just not to expose the patient to a significant change in fluid removal, in sodium increase by fluid removal or by solute removal. This can happen either in patients who are in CVVH, the same as patients who are in patients in CVV HDF, either with heparin or with citrate. This can happen. I think here, for example, ourselves in nephrology, something that we could do is just to ultrafiltrate the patient without actually providing dialysis. It would be a way to remove free water, and just by doing so, we might be able just to increase the sodium concentration in blood without actually exposing the patient to a dialysis fluid that has way more sodium than the patient has. Another alternative for our side would be, for example, to change the conductivity in the machines. Our dialysis fluid, it's usually set around 138, 100, but we can lower it as much as we can. We can provide a dialysis with a sodium of 120, and this would obviously allow the patient not to have a significant jump in the sodium we are getting. There are calculators for this, for continuous renal replacement therapy, although again, it's not very much use. It's only validated in math, so well, it's not easy. So I hope this is the end. I hope you don't leave today feeling like this, because I know it's not an easy subject. And well, I'm very happy to answer questions or to comment on things I've said.
Thank you, Paul. That's brilliant. I mean, I always find sodium to be really complicated. Actually, it's never sort of a straightforward one. It is something that we do come across on ITU loads. I mean, actually, by sort of coincidence, about 2 weeks ago, we had someone brought in from the surgical ward with the sodium about 108. It gone down from about 130, I think, about 4 days before. So it is something we come across sort of fairly often, actually. And it is one of those things that I guess it worries me, because I worry about sort of correcting it too quickly. I think, well, it certainly sort of generates a lot of anxiety. I presume similar for the rest of people, but one, you worry about sort of reaching for the hypotonic saline, and then you're worrying about sort of correcting it too quickly. And it feels like one of those things where it's not like sort of a pneumonia, or you come in, you give them the antibiotics, you put them on a ventilator for days. It's one of those things that does need kind of a close watch pretty much every hour, actually, and that's what we ended up doing with this patient. We ended up, we did give them, so this patient, they dropped the sodium to about 108. They were ataxic with a little bit of confusion, and we ended up giving them hypotonic saline peripherally. But yeah, within 2 days it had gone up, or certainly I think the next day it had gone up by about 10, and it then makes me sort of very anxious that, is this sodium going up too quickly? And the last thing in the world you want is sort of osmotic demyelination syndrome. That seems absolutely awful for patients. And it is one of those ones that just needs sort of real careful kind of monitoring and management on the intensive care, really. And it's not easy to manage, and then to actually get to the bottom of it, I still find it very tricky to sort of get my head around all the sodium stuff, even at this stage, really.
Yes. I think, well, just to remember that monitoring is going to be the most important part of the treatment. There are not necessarily wrong answers, but what is wrong is to give a treatment and not to monitor, or to prescribe a treatment and not knowing how to use it or what will involve. I think that's a mistake. But if you recognize that a patient has a severe hyponatremia, the patient is presenting seizures, or the patient is at risk of presenting them, well, try to proactively prevent this from happening, or, well, just reactively see if you can avoid overcorrecting. I don't know if you have experience here in your ITU to use Vasopressin. The more I read about this, the more I become convinced that it could be a good idea to have. I think it's a very good tool. Oh, there are other places that are using other things. So, for example, Baptans in United States, they are using. Here we don't. I also tried to see if we are having oral urea for patients who are not on ITU or who are not intubated to help them, but I couldn't find if we have that license here in the UK. I couldn't find it, so I suppose we don't. Part here is just to make sure that whatever the treatment we're doing is just to monitor, and that now we have tools to adjust the treatment. So for patients who has presented a quick overcorrection, well, to understand why this overcorrection has happened, it may not be because we were careless. It may be because just the own physiology of the patient is removing ABP, and now the patient is able to pass more urine. I think perhaps it was not very clear before, but in the formulas that I showed that the more urine you pass in these patients, once you begin to treat them, the quicker the sodium is going to go. Because remember, what you want is just to pass diluted urine or free water urine. So the more urine you pass, the quicker the sodium is going to go. So it's not necessarily that we made a mistake or that we were careless. It's just possibly because we are actually controlling or getting back to normal the physiology of the patient. But it's just another reason why not to be forgetful, why not to just leave it just for the rest of the night, but rather, well, to make sure if the patient has a line, well, just to get the blood test is not difficult.
Certainly, I think the sort of DDAVP clamp that you talk about is, I think it's really useful. It's not something I've ever used, but sort of read about it, and it is something that, you know, I very much was sort of getting ready to reach for that with this patient with the sodium that had gone up by 10 in about probably about sort of 15, 18 hours. I thought if that keeps going up much further, I'm going to have to do something about it, really. LRI, you've got your hands up. Do you want to? Have you got a question?
No, thank you very much for that. That was a lovely presentation on what is a difficult subject. The thing I just wanted to, I remember listening to a very similar presentation a few years ago and thinking, oh yeah, what's the chances that actually someone gets this? And so, as in central pontine demyelinosis, it sounds incredibly rare. It's so unlikely. I've corrected stuff much faster by accident and I've had no issues. Up until we had a case of a patient who was a malnourished alcoholic who came in, and unfortunately in the recovery phase after a significant variceal bleed, had a correction of sodium, which was not accidental. It was just purely him getting better, that was faster than we would have liked, and then didn't wake up and had an MRI scan that showed that he had features of CPM, which I was really I was surprised about. So it isn't something that doesn't exist. It's just to be very, very cautious around all of this when you're treating and monitoring as suggested, really.
Do you know how quickly that sodium went up by Mike, over what sort of time period?
It was around, I think it's about 10. It had corrected slowly to begin with, and then suddenly there was a reasonably fast correction of about 10 millimoles over 12, 24 hours. So it was just a sudden correction.
Yeah, it's certainly one of the things that you read about, and
Yeah.
I mean, I don't think I've ever met anyone with it, but I suppose it's sort of sobering to hear that it isn't just a sort of textbook thing that you're always in the exams, and I suppose life in general, you worry about taking it up by more than 12 in the sort of 24 hours.
Yeah.
But it's kind of sobering to hear. It does happen really, and it's
exactly that, and that was the thing. I just thought I'd share it. That it's one of those things that I probably won't get another case of for the rest of my career, but it is something you just need to be wary about. It's not just, as you said, the textbook thing.
I think in my experience, like what I've seen here in the UK, and obviously I didn't train in the UK, but I come more from an American system, is that they all love guidelines and they all love formulas and to predict. And I think one to learn is that sometimes patients are also unpredictable. Again, I think it comes to the fact that we have to be aware that many times patients, the moment they begin to improve on their own, is when the correction pace is going to be quicker, and that's when we're going to get into trouble. And we must not forget that. So, despite the fact that we may have formulas to try to predict how they are going to correct themselves, they may not be enough. The more formulas they develop, it's never going to be as the same as just actually monitoring the sodium by certain hours, and being open to accept suggestions. For example, if there is a consideration to use this DDAVP clamp that I don't know again if experience here, but if someone wants to give it a try and there can be consensus between, I don't know, nephrology and ITU or so, I mean, perhaps it's a good moment to consider it.
Yeah, no, just so I missed the exact bit of what you described it as how you do this, the DDAVP clamp.
So what you do in the DDAVP clamp, can you see the last slide that I have there, or you can't?
I can see the just the head and hands.
Okay, let me see. This is the last slide, although I didn't show it, but can you see on the right side of the screen the diagram that shows the clamps? Can you see it?
Yeah.
So the rationale of the clamp is just that, is just to try to avoid the rapid correction and just to try to keep things in place. And the way they do it, these guys, let me show you the way they do it, is they provide with two they provide with 2 micrograms every 6 to 8 hours of DDAVP. No, it's not there. So, you know what? I think I made a mistake and I may have not put the dose. But the dose to achieve this is just to give 2 micrograms of DDAVP every 6 to 8 hours. Yeah, I'm sorry, I didn't put it. The dose would be 2 to 6 micrograms of DDAVP every 6 to 8 hours.
Yeah.
Well, just monitor the sodium all along. In some places, what they do is along the DDAVP, which is what you can consider on this slide, which is the green needle, is also the sodium that you're going to be given. So either 0.9% sodium chloride, if you're going to go for the 3%, or if as a rescue therapy, you need to give the 5% dextrose. But the whole idea is that when you provide DDAVP, what is going to happen is the patient is going to decrease the urine output. So that will provide you with extra water to the sodium diluted. I can look for the papers to send them to you if you like. I'll send them to Ricky, and I'm sure they will be able to share them with you if you want.
Yeah, that would be lovely. It sounds like a lot of DDAVP when we're still used to using, well, obviously not in the same situations, but used to using sort of half a mic, and not very frequently. But obviously, we're less kidney and more brain at that point. We're using it for.
Yeah.
Lovely. Thank you very much.
Okay.
Vikal, you put your hand up. Have you got a question?
Yeah, hi, thank you, Ricky. Hori, fantastic presentation. Thank you so much. One of the things what we're currently facing is in lots of elderly population who are coming for the orthopedic procedures, who have been on lots of diuretics. And often we are seeing is the sodium is in the regions of mid 120s or early 120s. And they present on the day for the operation. And it's really hard to cancel their operation. And some of the times we have done them and not had any problems, but some of the times we did them, leading to more fluids to be given, and afterwards they becoming hyponatremic.
What?
As expected. Is there, I know there's no magical answers to anything. Is there something like in these people who are given chronic diuretics, some place for them to be monitored, especially now because we'll be losing our capacity on HDU?
I don't think I can tell you exactly where to put them. But for example, these patients are the ones that in other centers they are considering for urea tablets or for urea sachets, because it does help. It will make sure that the sodium goes a bit higher every day, but not very high. It's a very slow. So these patients, they don't need a lot of fluid. Also, one of the things to remember is most of these times hyponatremia, they don't correct it by getting more fluid into the patient. The only fluid that you can give is just the sodium 3%, the sodium 3% rest. It's not part of the treatment. So more fluids is more hyponatremia, so patients stay here the longer. Most of these patients, they will require know what cause it is, to try to remove the cause of it, to try to limit a bit the fluid intake. I really don't have an answer for you to where to put them, but I know that there are patients who would benefit from not necessarily ITU approaches to get to them back to a safe sodium where they can have a surgery. I don't think I'm helping that much with this explanation though.
No, I think I've got my answer. But thank you. Thanks again, Howard. Thank you. Lovely presentation. Really enjoyed it. Thank you.
Okay, I think that probably draws it to a close then. So in the chat, we should have the feedback form, either a link or also the QR code. If you can kindly scan that, that'd be great. But thank you all for attending. Thanks again.
Thank you. Bye, Ricky. Bye, everyone.